Hello everyone. Today's video is another Q&A video talking today about antihistamines for folks who have trouble finding antihistamines that they can tolerate, and then some questions about sinus mold and fungus balls and ozone up the sinuses, and maybe some other questions if I have time. So see how chatty I am today. As per usual, nothing I'm saying should be construed as medical advice. This is for informational purposes only. If you have medical questions or need healthcare advice, please talk to your healthcare provider. And if at some point you don't mind taking a moment to please like, share, subscribe, and or post a quick comment on the video, I'd really appreciate it. So thanks in advance for taking a second to do that. As you can see, I'm still doing my casual wear videos, still working from home. I have a family member in the hospital, and so just working from home for the next little while. So anyways, just nice to have a chance to still make these videos, and just not as fancy as my normal videos, but hopefully the content will be just as good. So first question here was on another video that I posted 9 months ago. It's called H2 versus H1 blockers for MCAS, and it's just another Q&A video. So she says here, thank you so much for taking the time to answer these questions. I'm having trouble finding an H1 blocker that works for my MCAS symptoms without having side effects that render me unable to do my job. I only have 2 more to try, which are Zyrtec and desloratadine, if I can find it without corn. Do you have any suggestions for what to do when an MCAS patient can't find any antihistamines that are acceptable to take daily? Can regular cromolyn sodium be a decent replacement for H1s? So yeah, thanks for the question. Yeah, sometimes that's a real challenge / struggle to find antihistamines that a person can actually tolerate, because they can be such a game changer for folks who are dealing with MCAS, but sometimes you just can't tolerate the side effects, so it's tough. So my heart goes out to you on that one. Yeah, at the end of the day, it's really a matter of, in my experience with my patients, just kind of running through the available antihistamines and hopefully finding one that works. I don't say this to be pessimistic in any way, shape, or form, but like with my patients, if they've tried, a couple of H1 blockers, or a couple of H2 blockers, a couple of H1 blockers, bearing in mind there's the first and second generation H1 blockers, the ones that cross the blood-brain barrier, like Benadryl, and then the ones that don't, like Zyrtec, also known as Reactin, the desloratadine, others like that. Then, if they've tried a couple and they're not tolerated, I'll usually just give up at that point, to be perfectly honest, because the writing on the wall is usually that if that drug class isn't working, sometimes another option in that class will work, but oftentimes it doesn't. So I just don't want to put them through the suffering of, reacting to this H1 blocker and that H1 blocker and that one, where it's like, okay, the writing on the wall is maybe this just isn't the best fit. Cromolyn sodium is great. To be honest, patients where I practice, we have a really hard time accessing that. But from what I hear from my colleagues, and I have patients from all over the place, some of whom are on cromolyn sodium, it can be really, really great treatment. So I'm a big fan of it. And I wish we had more access to it, because it would give patients more options. So I think it's great. So in terms of other options, then, really it comes down to, to my understanding, there really aren't any non-pharmaceutical alternatives to the H1, H2 blocking drugs. And sorry, you're just asking about H1, so I'll keep it to H1. There really aren't any non-pharmaceutical alternatives. One of my mentors, brilliant doctor, Dr. Jill Krista, when she was on my podcast, I believe during that interview, she said that, oh my gosh, not milk thistle, stinging nettle root, I believe, does evidently have some histamine 1 blocking, but H1 blocking potential. I haven't really played with it much in practice. It's kind of been on my to-do list, so I can't really speak to that, but there might be some angle there. I trust her implicitly. I don't know how potent it would be compared to the actual pharmaceutical options. But for all intents and purposes, for the most part, unless there's the stinging nettle aspect that I'm just really missing the boat on, then I think that from a non-pharmaceutical perspective, really what we have to offer is mast cell stabilizers like quercetin and luteolin and PEA and things like that. And then, of course, treating the root cause of what's actually causing the mast cell activation in the first place, which I'm sure goes without saying, but I'm saying it anyways. So whether it's SIBO or Bartonella or mold or some other cause of that, sometimes it's a stress-related thing, it's an amygdala dysfunction-related thing, sometimes it's more than one of the above. One other angle that we can intervene in this regard, in a non-pharmaceutical way is working with cofactors to help the histamine metabolizing enzymes like HNMT and DAO and aldehyde dehydrogenase and MAOB, monoamine oxidase B. I really haven't seen that approach move the needle very often for patients. I used to use it all the time and just found that like some patients, yes, it would help, and then in a bunch it didn't. So I don't really do that a whole lot, but it is just trying to be thorough with the video topic here. So yeah, I think that's pretty much all that I have to say about that question. If the person asking the question has any additional follow-ups on this, I'm happy to elaborate on it more. I think MCAS and this topic is just endlessly fascinating, and I know there's more and more info coming out there, but I know not a lot of clinicians talk about it. So anyways, happy to talk about it more, share what I know, but I hope you find good success moving forward. So other questions here is a pretty quick one here. So it says, so this was on a different video called, the video about a very difficult case of sinus mold colonization. And so for that one, it says, is there any reason you would recommend against surgically removing a ball of mold found on a CT scan in the sphenoid sinus? So again, not giving any medical advice here over social media, but I know if I had a ball of mold in my sinus, I'd probably want to get it surgically removed. This nasal sprays and nebulizers and things like that we work with, they're very, very good, but I'm generally of the opinion that if you can physically remove something from the body, as opposed to try to treat it more systemically, usually better to go with removing it. That goes for like cutting out tumors, that would go for removing mold balls or fungus balls or things like that. So I think generally speaking, that's something that I would very likely consider if it was me. So good luck with the ball of mold. I hope it's dealt with quickly one way or the other. And then on the same video, there's another question. It said, I purchased an ozone machine for a difficult case of MARCoNS, which is multiple antibiotic resistant coagulase negative staphylococcus. So a certain type of staphylococcus bacteria colonization on the sinuses. How often should I use it? So I appreciate the question. I know you're trying to trick me. You're asking me to give you, medical advice here and dosing advice, which I know that that I won't. So I thank you for testing me, and I will not give any medical advice. But just somebody then also posted, how are you planning to use it? If you simply breathe in ozone, it will ruin your lungs very quickly and likely permanently. And this is why ozone is one thing I would not mess with, and move on to other options. So when it comes to ozone inhalation, I couldn't agree more with that comment that breathing in straight ozone is a terrible idea. I'll come out and say that, I think it's a bad idea to breathe in ozone, and that's something I think is universally agreed upon. However, there is a treatment that's called an ozonide inhalation, which is where the ozone is percolated through olive oil. Other oils would probably work, but I've only ever done it with olive oil. And then the ozone, it reacts with the olive oil so basically it's percolated through a device called a bubbler. And so basically the ozone kind of bubbles down through the oil, and then it is, what goes in must go somewhere. So then that ozone that's now reacted with the olive oil, the double bonds in the olive oil creates a byproduct called an ozonide, and then you have these ozonides, the kind of like a vapor form of ozonides percolating up to the top of the bubbler. That comes out the tubing at the top of the bubbler, and then that's attached to a nasal cannula, and then that's what's breathed into the sinuses. And so there have been a few research studies done using that method, and that's something we've used in my clinic in the past extensively. Other clinicians use this treatment as well, and it's not irritating to the lungs at all, as best we can tell. And we can tell that because when one does breathe in ozone, accidentally, as happens sometimes, then it causes like crazy coughing fits. It's very, very irritating to the lungs. Whereas ozonide inhalation, we have patients who have been on, 15, 20 minutes, breathing in these ozonides, not a hint of a cough. So it seems to be pretty good clinical evidence that the ozone is no longer there. It's now an ozonide byproduct, which does not seem to be harmful to the lungs at all. Now, that being said, we don't do ozonide inhalations very often anymore because I found a lot of the nasal sprays and nebulized treatments like essential oil nasal sprays, essential oil nebulizer treatments, silver nasal spray. I find that those treatments just tend to work really, really well, and it's just way easier and more cost effective for patients to just do their treatments at home. So we don't really do a whole lot of it, but it has been very, very helpful for other patients in the past. Thank you for the questions as always. I hope this was useful. Any other questions, just post in the comment section below.